UK and the TKR, and then now we are coming to the revision. But thank God we are not doing the infection. Now, with that, I come to how do we, techniques of taking out a revision. Now, before we do a revision knee, the most important thing is we must know what was the original disease, what was the design of the prosthesis that we had used, the mechanism of failure, and whether it involved any technical errors. And only after understanding all of the above, only then we go to the implant extraction. Because when doing a revision, there'll be a lot of repetition among all of us, but because when we're doing a revision, we need to know a lot of things. Because the main aim would be to restore the joint line, we need stable implantation, and to implant removal should be carefully performed. It should not be done by your registrars or any junior surgeons, and I think the most important part of this should be done by a very senior surgeon. And most importantly, you have to preserve the host bone, because as you know, the host bone is either thinned out or it's very osteoporotic, and it may be technically very challenging. Now, thorough preoperative planning. I think all the speakers spoke about preoperative planning. I think to get good results in everything that we do in our lives, it's all about preoperative planning, and especially in surgery. So with that, we come to preoperative planning. Number one, we have to identify the mode of failure. We must exclude sepsis. We had spoken about sepsis before. We must assess stability and determine the size of the existing prosthesis so that we know what kind of prosthesis that you're going to use. And of course, you must estimate bone loss and whether you have contained or non-contained bone defects. And of course, you choose your new prosthesis. And choosing of your new prosthesis means how much of bone, host bone, is going to be left. Now, with that, you know that to determine the size of the existing prosthesis, you may have to just look at your operation reports, if you have them, if it's done in your hospital. If they are not done in your hospital, then you probably have to try to get some notes. Look at some scale radiographs and look at the normal knee. And CT scans may be very useful while doing a removal, because on looking at the x-rays, we have a tendency to underestimate what we actually see. And these are the types of implants they may require depending on the types of defect, whether it's a type 1 defect, a type 2 defect, or a type 3. And you know, in the type 3 defects, we don't use so much of SROMs from the part of the world that I come from, Malaysia, but I think they use a lot in Australia and the other parts of the world. Now, coming to the crux of the matter, how do we remove the component? Number one, you have to work very close to the undersurface of the prosthesis between the bone and the cement interface. This is a very important take-home message, because you have to work very, very closely to that, and do not at any point lever on the bone, because when you lever on the bone, the leverage may actually fracture or cause microfractures into the bone, because these bones are technically very soft most of the time. And you may even want to use some saw and thin osteotomes, which are available in most hospitals. I use a lot of giggly saw, and I think that you may have to use maybe more than one giggly saw, because when I talk about the femoral component, you may need a little bit more than that. And I use a lot of high-speed burr. I use the Midas Rex. And implant-specific extractors, if you're using, depending whichever company or implants that you use, I think they have the implant extractor that comes with it, so you may want to use them. Now, I always start with removing the femoral component first, because I find that easier. And you may want either use an osteotome to break between the bone and the prosthesis interface. And you may want to use the giggly saw, and it's easy up to this interface, but at this corner is where most of the time your giggly saw may actually snap, and you may have to use another one. And this is using the Midas Rex. You can use a burr, and you can actually just knock that out, and that should come out quite easily. And after which, then you may want to get into the femoral component and work between the implant, the cement, and the bone interface. That's where you want to put your son, and never lever on it. Now, coming to the patella may pose a little challenge, because in Asia, most of the patellas are only about 22 to 23 millimeters in diameter, unlike the Western Caucasian population where you have nice big patellas. Now, if you're going to remove the patella, I suggest that you can cut off the patella, but take off the implant, but leave the pecs alone. because by trying to be overzealous in trying to remove those specks, either with a curette, you may actually create more bone damage. So use a burr and gently just take them out, and I think they just come out quite easily. They just peel off. Now, after doing all that, of course, you have to have your reconstructive options ready. You have selection method will depend on the functional demands and comorbidities of the life expectancy of the patients. Most of them come when they are revision are probably in the late 60s or 70s, and restoration of bone stock is preferable. You may want to have bone graft in your arsenal, and because they can be easily contoured. Stems are important because all this will be useful, because depending on how much of bone that you're going to take, because Insall said that 84% of excellent midstream results on long stem techniques. And this is what you want to do after removing the implant. You may want to, that's the key take-home message is to restore the joint line. And how would you restore the joint line? I think all of you would know it's either 1 finger breadth above the fibula head, or it's 30 millimeters just below the medial and 25 millimeters below the lateral epicondyle. That's just an estimate on how you would do that. And of course, these are some of the contained and non-contained bone defects. As far as the contained bone defects are present, I think that's quite easy to handle. But the non-contained bone defects, I think you need a lot of autograft, and you may want to reconstruct with allografts as well. Now, when you're combining with allografts and augments, these are things that you may want to consider in your arsenal after removing those bones. Now, to summarize it all, I think the most important thing is the preoperative planning. And in the preoperative planning, you've got to make sure that you have everything ready. You've got your giggly saw ready, your osteotome, your thin osteotome ready. Your Midas Rex is an important tool, and lots of lavage when you're doing this. And of course, you have to prepare for the worst with prosthesis and bone graft options. Because at the end of the day, you only have that one option, and we are talking about a revision case, not an infected case where you may be doing it in stages. So in a revision option, this is what you have to do. And just to add, because I'm going to talk about transaminic acid tomorrow, but I tend to use transaminic acid now when I'm doing all the revisions because there's a lot of blood loss. But since I'm talking about it tomorrow, I'm not putting that in my slide. So with that, gentlemen, I leave you either in pain or ecstasy. Thank you.